questions, anyone? If anyone wants to ask in Hebrew, I'm happy to translate.
I would like to refer the question to Professor Anita. What is your approach now when you do a whole genome sequencing directed to look for a specific disease or a research trial, and then you do find genes on the way that have clinical implication? Can you sign the patient before to breach him from not disclosing any other genes that have clinical information? Like what do you do in Great Britain now?
Okay, so it's slightly complicated in the UK by a new venture called the 100,000 Genome Project, which is a very strange venture because it's run by the NHS, the National Health Service, where people coming in for investigations are offered this, but it's a joint clinical and research venture, and it's very uncomfortably on that interface. So on the one hand, it's got a very long information sheet and consent form, which is the sort of research arm, I suppose, for taking part in the future and allowing pharmaceutical companies access, etc. On the other hand, it's promising a diagnosis that up until then has been unavailable. So it's saying here's a fancier test than you've had up until now that might find something. It's in answer to your question, I think, which is about incidental findings, really.
Yes, again, what is your obligation as a genetician to inform about genes that were found when you were searching for something else?
So my interpretation of that would be that if I find something that I think is clinically relevant, then I will disclose that regardless of what consent was like up front, because I think it's impossible to give consent to infinitely variable outcomes. Now, I don't claim to be in a majority there, but that's my take on it. I think that consent is almost in the wrong place there. When you're talking about something that's so complex and so there's so many different outcomes, and if you think about it, there are very few people who understand the whole package of testing a genome, that understand what it means to do in the lab, what it means to interpret. How can we expect patients to give fully informed consent, which is what we aim for? I think we can only expect patients to give very broad consent because that's all you can possibly give when the outcomes are so varied. Then I think what you have to do is say to the patient up front, this test might diagnose your condition, but if we find something that's treatable or that you can do something about, then we will also disclose that. And very few patients will say, no, you can't do that. I think your earlier point, I think it was you, wasn't it, is where do you draw the line? That's a really difficult one. How high does that risk have to be? You find something and in some paper that you've seen, it gives a risk of psychiatric illness in an adult that's possibly increased. Do you give that? I think you have to do it on a case-by-case basis. And I think the Genetics Forum is full of those now of, do we disclose this or not? Is this a VUS or a VOUS, or is it actually a significant finding? I'm giving you a very long and rambling answer because I think there isn't an easy solution to that. I think we need to address the fact that consent is slightly in the wrong place. We sort of think, well, what's a patient consented to? Then we can disclose it. A patient can't consent to infinite numbers of outcomes. And once you accept that, I think it becomes easier to disclose things. But at the same time, I think you can apply filters to your genome so that you don't find absolutely everything. Yeah, exactly.
Any other questions?
I would like to ask a follow-up on that, on developments.
Yes.
Something that you check nowadays, or you get information. You as a geneticist, you meet the person at one time. It might not be treatable.
Yeah.
But in the future, although you have that information, in the future, I'll give, for example, I don't know, Huntington, for example, now it's not treatable, but it might be treatable in the future. How do you continue to, if you have that information, let's say you decide not to give this information at this at the present, but in a few years' time it will be treatable. How do we make sure that this information that was gathered and is somewhere
Yeah.
will be given to the patient.
I think that's a really good question. And the flip side is also important. What if you give the patient a result that you now think is clear, but actually you realise is far from clear or gives another risk as well? And I think both of those are big issues that the health service in the UK is not well set up to address. I don't know about in Israel. But we're doing a research study at the moment which is entitled Duty to Recontact, which is all about, do we need to go back to people and provide a sort of follow-up? I think it's useful to think of, if you've had your genome test, to think of that as a resource that you might dip into over the years. And we might need to establish some sort of joint responsibility between the health professional and the patient to revisit that at regular intervals. But obviously that has a lot of resource allocation implications and making sure that patients know when to do that. There are no answers out there yet, but I think you highlight very nicely that we need to think about those issues, because we're, in the past we do a test and we just do it again. In fact, that's an answer that some people give. Actually, let's bin the genome and just run it again if we need to, because it'll get cheaper and cheaper. But it still leaves that question of, your genome will be somewhere 5 years down the line. Is there a duty somewhere on the part of the health professional to recontact patients who might have moved, to let them know that the interpretation is different? I think there will be some duty. How it will play out in practice, I'm not sure yet, and I don't think anybody knows. You might know.
Well, no, I'm just thinking and following what you said, and I think there is the fourth dimension, which is time. And again, what we're used to in genetic counseling and the genetic counseling session, that it's a one-shot thing, that you come in and you get the information either before you perform a prenatal diagnostic procedure or after or before you do any other test. If we would envision a genetic counselor like a GP or something like that you will follow with different interests through the years, then perhaps we're dealing with something else, because genetics is going to be the future medical. Then perhaps we should think about that, and the genetic counseling profession should actually sort of think about that.
I think you'll need a lot more money, won't it? I mean, that's another thing that's been proposed, that a way of recontacting might always be via the general practitioner. I don't know, does that work similarly in Israel as it would in...
Not really. Yeah, it's a different but
Oh, suddenly hands went up.
so you first. So.
Okay.
My question has to do also with the legal aspect. Is there an implication if you don't reveal, and then the person could actually sue the doctor for not revealing it? And if it's a patient doctor, it makes sense. But what if it's the second or the third generation or distinction? Can they sue the doctor?
Because we try.
They can, you just can't, because the law says that you can say, you might say, you don't have to say. Okay? The doctor don't have to say anything.
You can always sue.
You might be only in you say, but the law doesn't say that.
But what I find interesting is the doctors, according to Annika's research, was they almost across the board said, don't disclose. Almost on everything where there was a question of disclose or not disclose, the doctor said, not us. We don't want to.
So they weren't saying don't disclose, but they were saying it can't be our job.
Right, they were taking our responsibility.
Yeah.
But then, if there's a case of a lawsuit, even one malpractice suit or one non-disclosure lawsuit could really probably harm a doctor.
Absolutely, although that's actually used as an argument for them not disclosing. So what they're saying is, we don't think it's our job to disclose, we give that duty to the relatives, because if we accept it as our job, then we're going to get sued a lot more often. So it's actually quite a sophisticated argument. Well, they can't do everything because where do you draw the line in terms of, how serious does the risk have to be? How certain do they have to know about the risk? And everything, when you've got 3 billion letters to talk about, is quite a lot, and there's an awful lot of uncertainty then. So I think actually they'd rather tip it the other way and say, we'll only disclose the very certain treatable things, and everything else we'll leave it to the family to disclose. So there's two issues there, I suppose, packed up together on them. One is about disclosing to the patient, and the other then is about how that's transmitted in the family. And I think certainly in the UK, health professionals don't want to take that on because they think that's just a step too far. They don't know where the line would stop. So they're scared of it. I think with the sort of joint account approach, you can actually do a lot that would prevent lawsuits, but it moves against the conventional view of the patient in question quite a lot.
אני רוצה להוסיף, אני עושה בעברית, ולסייע פה לעצמי ולשאר הקהל, שמתנהלת היום תביעה, יחידה וראשונה מסוגה בישראל נגד...
יכולה לעמוד וקצת יותר בקול?
כן.
עם המיקרופון, יש מדע.
מתנהלת היום תביעה נגד יועצת גנטית, למעשה, תביעה של קרובי משפחה שנולד להם ילד חולה, בעוד שבני הדודים היו מטופלים במרפאה גנטית אחרי שנולד להם ילד חולה, ומספרים למה אף אחד לא אמר לנו. יש תביעה כזאת, אומר הצד השני, אבל אנחנו לא צריכים להגיד לכם כפי שפורט, והטענה היא, אתם לא אמרתם לאותם חולים, משפחה חולה ראשונה, נגיד ככה, לא אמרתם להם שחשוב שהם יגידו לנו. לא אמרתם לנו, כי אין חובה כזאת בחוק, אלא לא אמרתם להם שהם צריכים להגיד לנו. וזה יש בחוק. לא צריכים, תגיד להם שהם צריכים את המשמעויות לקרובים. הטענה היא שהם לא אמרו. ועל זה הם מתווכחים עכשיו, אמרנו, לא אמרנו. אבל התביעה היא צריכה ללכת מסביב. זה תמיד נכון.
The other thing about lawsuits is you can always find one that goes both ways, so they don't necessarily help you in knowing what the right thing to do is. I don't know what the law's like in Israel, but in the UK it's very much like the US of case-based law, judge-made law, and you can usually find a case that tells you to go one way. So in the States there's an argument about one case that showed the doctor did have a duty to disclose to relatives, another one that said the opposite, and it sort of stopped at that really. So yeah.
I don't know if that's the same in Israel.
Same.
בישראל תמיד אפשר לתבוע, זה הכלל.
We're both coming from the world of socialized medicine, but no one has addressed this evening who owns the information because they paid for it. And if the individual paid for the test, then he owns the information.
Yep.
And his obligation, or is his choice, to disseminate that information that he paid for. And I think that puts a tilt on the ethical issues that we're discussing here. Because a person can come in and say, this is my information about me, and I paid for it. They didn't pay for it, therefore they don't own it, therefore you can't share it.
Yeah, I mean, Shiri knows my views about ownership because we've had these discussions lots of times, haven't we? But I think ownership is a bit of a red herring. You're right, it plays a real sort of emotive argument, doesn't it? I own it, so therefore I should be able to do what I want with it. But, you know, I might own a very sharp knife and it doesn't tell me I can do what I want with it. There are limitations on what I can do with that ownership. And I think we'd argue something similar about ownership of genetic information. You own that particular result, but that doesn't mean that you have a veto of communicating that to other people. Yes, you've paid for it, that's fine, but it doesn't actually tell me what you can do with something because you own it. But I think you're absolutely right. People do take the ownership route as giving us answers. But I would suggest that in the case of genetic information that's shared, all you can say is, well, you own that particular result, but we know through your result that somebody else has got the same result who's got it for free, and now it's a matter of communicating that to them. So personally, I don't think ownership really helps us in answering some of those ethical issues. It does, yeah.
We want to do genetic testing, right? The state, especially in the socialized medical abuse, the state wants to make sure that they're not going to have these burdens, these...
חוק מידע גנטי אוסר, אנחנו המדינה הראשונה, כבר לא היחידה, אבל הראשונה שחוקקה חוק מידע גנטי שאוסר על המדינה לבצע או לברר מה התוצאות של הבדיקות שלה. לחברות הביטוח.
Maybe
Gina Lowe also provides.
And maybe a better analogy rather than a knife, is to think of if you buy a CD, you don't buy CDs anymore, do you? But a DVD, that you own that DVD and you can play it and you can share it with your friends, but you don't own the copyright of the film on there. And we could think of genetic information a bit more like that, of copyright on a DVD that, yes, you have purchased, but you might still not be able to do whatever you want with it.
In the UK, to what extent are the representatives of the religious establishment involved in these discussions and committees in terms of the ethical aspects?
Yeah, good question. I mean, I think most of the debates about the ethical aspects are run on a very secular level, and they might ask for input. So on our clinical ethics committee, we always want the hospital chaplain because we think that gives a very useful input, and we've got an imam who helps us to deal with questions from a Muslim perspective. But the level, on the level of creating the law and professional guidance, I'd say that's probably has much less religious input than I imagine here.
Any other questions?
Maybe I'll take it, elsewhere. To informed consent when it comes to, I'm coming from the world of big data.
Yes.
Okay, so you started with whole genome, and we want to translate it, you can say, in favor of the whole population, right?
Yeah.
I don't know what's going on in Israel. I more or less know, but I'd be happy to hear what's going on in the UK. What do you do with the informed consent of individual that is coming to test for BRCA 1 or 2, and then we want to use this information globally.
You mean in a large data, in a biobank or something? Yeah, yeah. I mean, I think that's really important because there's a big disconnect between the clinical output for something like BRCA and collecting enough data sets in order to interpret some of the BRCA variants that we can't yet interpret. And there's been a lot of calls recently to have more big data put up, but I think we've got a long way to go. So I think we're moving that way slowly, but there's a big fear about privacy invasion, which is a sort of panic fear really rather than a very specific one. But there's a big tension between collecting large enough data sets and people worrying about them being identified somehow through that data set.
Yeah, the problem with the cloud.
Yeah.
In Israel, we have two huge sick funds, Maccabi and Khalid, and each one of them has a huge population, let's say a couple of millions, even though we are only 6 or 7.
Yeah.
But anyway, it's a huge data that could be used. And you can use it for, diabetic and cardio and stuff like that, but once you touch genetics, that's where...
It's interesting that, isn't it? So you can get a lot of genetic information, say, from your cholesterol levels. That's okay, but as soon as it's talking about genetic code, it feels very different. Yeah.
So no colorectal cancer, but you can look at your colonoscopy, but not to see,
And so I suppose in there comes a prediction. People want to know what they've got now, but they feel a bit less comfortable about predicting something in the future and how to handle that. But it's very interesting. It's been ever so good.
Thank you, everyone. If it's okay with you, we'll send you an email with a short feedback form that we'd like you to send us back so that we can learn for future events. And we'll be happy to invite you to future events, so you may have additional emails in the future. We'll ask you if you don't want to have these emails, please let us know. Thank you, Anneke. Thank you, Smadal. Thank you, Goldie. Good night, everyone. Drive safely.
Such a great audience.